those in low-income countries. I went out to Africa with the Wellcome Fellowship, and then when I came back, I was writing up the findings and saying this should inform vaccine development. The pharmaceutical industry came to me and started offering me jobs. So I'm now on my second pharmaceutical job, which I started in December with Pfizer, but I still have a group at the Jenner Institute up on the Old Road site, and a position at the University of Birmingham. And as Lynn mentioned, I do still manage to see patients in the immunology clinic up at the John. Good. Let me just see this one. Everything is forward. Yes, frozen. That's absolutely fine. I'm very happy to do it on the keyboard. So, as the delivery on the slides will point out from slide one, I'm now an employer of Pfizer UK, and that's a requirement of apparently the Association of British Pharmaceutical Industries that the new slide has Pfizer on it. But I just have to say that this presentation is no different from the one I put together and presented in November before I joined Pfizer. So you're not going to get any Pfizer stories today. This is the story that I put together. So if we just turn the clock back now to the discovery of antibiotics and Alexander Fleming going for his Nobel Prize in 1945. It's really very sobering looking back now to realise that he already realised there was a threat looming of antimicrobial resistance, and he did warn the world about it in his laureate lecture. And the words are here about it. It's not difficult to make microbes resistant to penicillin in the lab by exposing them to concentrations not sufficient to kill them. So that threat was looming right back at the start of the antibiotic era. And as Lynn mentioned, this lecture was it was actually for the annual with the Royal Pharmaceutical Society annual lecture, which was held last month. So I did put a few definitions in which aren't necessary for this audience, but in relation to antimicrobial drugs, we'll focus on antibiotics. In relation to antimicrobial resistance, AMR, the focus of this talk is very much on bacteria, and of course resistance is essentially encoded by genetic mechanisms that are naturally occurring within bacteria and allowing a survival advantage, so this microevolution to occur and allow spread in the face of competition from other strains. And I'm not going to go into the mechanisms because there's really not time in this talk, and that's not really what this talk is about. So you're already aware that there are multiple mechanisms of resistance against antimicrobials, against antibiotics. And I think the bottom line that I want to get across as an immunologist is that when we think of drugs and antibiotics, we're looking at one binding site, one target at its most simplistic form. And that's important to remember when we think of the wonder of the immune system. So the UK has actually been quite a leader in this place, in this whole space. And back in 2014, David Cameron commissioned Jim O'Neill, now Lord O'Neill, interestingly a macroeconomist, not a medic, to review antimicrobial resistance and to look at that from very much an economic perspective and recommend solutions. And a couple of years later, Jim O'Neill came back with his report, which really has been a landmark and has been an anchor for activities that have occurred in the following 10 years. And actually the information that came back from that report in terms of the predictions was very sobering. So the prediction was if you look forward to 2050 and you don't take steps against antimicrobial resistance, there'll be 10 million deaths annually from AMR from a predicted 700,000 in 2016. And the cumulative economic loss in terms of global output would add up to $100 trillion, which is a sum that's very difficult to get your head around. even if you're the new President of the United States. And O'Neill put together a 10-point plan. And it really comes into two main sections: reducing demand, and this is partly around global awareness and improved water, sanitation and hygiene, improving use of antibiotics so that we stop inappropriate use, and promoting development of vaccines and alternative therapies, so, and having diagnostics as well. So the vaccines there are red. In the second section, it's really increasing the number of effective antimicrobial drugs. And within that, I think most people in the audience might like point number 7 about improving the pay and recognition of people working in infectious diseases, especially those who are. And the last point was quite important, and this was around building a coalition for action on antimicrobial resistance. And specifically, the G20 and the UN were included in that. And part of the reason that this is important, and the problem is that my face is over the critical figure there, and I don't know if I can just move that with my mouse. Let's move that over Pfizer. Disrespect. So don't report me for this. The estimated cost of this global action on AMR is $3 to $4 billion per year. Now, that is a huge sum of money, but in the context of $100 trillion at the cost projected by the report from 2016 to 2050, it isn't. And I think it's just worth bearing that amount in mind. And coincidentally, there was also that year a first United Nations high-level meeting on AMR in New York. This wasn't just the first meeting on AMR. It's actually quite unusual for the United Nations to hold high-level meetings on anything medical. So, and so this was really quite a watershed moment. It took advantage of the fact that the WHO had also put together a global action plan the year before, and that was used as a blueprint. And there's a certain amount of overlap with this and with the O'Neill report in terms of increasing evidence and knowledge base, having more prevention, optimizing use of antimicrobials. And there's also the economic case was underlined here as well, which the O'Neill report had built out. This was then linked into the UN 2030 Agenda for Sustainable Development, and although I won't go into that, there are aspects of that which very much translate across to what AMR and dealing with AMR drives at. There was an emphasis on developing resourcing national action plans, and a need for new antimicrobials, new vaccines, and new diagnostics. And in fact, the following year, in terms of that economic consequence, and linking back again to the O'Neill report, the World Bank produced its own report, and the scope of that had been to look at what the economic consequences would be from AMR, both in terms of economy and development from a global perspective. They used their economic simulation tools, and they looked at what the effect of AMR would be in terms of shocks to labour supply and livestock productivity. And really the remit was to put a price tag on what this would involve if there weren't adequate measures to control AMR, very similar to the O'Neill report. And in fact, the careful modelling produced outcomes which weren't dissimilar to the O'Neill report either, but just gave a little bit more granularity. So a fall in annual gross domestic product by between 1% and 4% by 2050, and there are the curves to show on the figure on the left, with an annual GDP shortfall of 1 to 3.4 trillion by 2030. If you add that up, that's not dissimilar to what Jim O'Neill predicted. And then an annual reduction in global GDP, which could have losses on an annual basis as large as what we saw in the 2008 global financial crisis. But the problem is it would carry on year after year after year. And the other thing that was important as well as that figure was the impact was going to be felt largest on low and middle income countries, unlike the global financial crisis, and it would increase economic inequality. But we still didn't know what the actual estimates were of number of deaths to do with AMR, and the Institute for Health Metrics Evaluation, which does the global burden of disease studies, got its act together and published 2 studies in The Lancet in 2022. Interestingly, it published the study on AMR first and then thought, oops, we should really have published what the burden of bacterial deaths are, which came out second. And these are basically shown in the model figure on the left of the screen here. So total annual deaths due to bacterial infections, 7.7 million. So that actually puts bacteria as the second leading cause of death after ischemic heart disease. In terms of AMR, deaths associated with AMR, almost 5 million, and those attributable to AMR, so not just in the causal chain, just under 1.3 million. And again, the burden highest in low and middle income countries, so resonating with what was predicted by the World Bank report. So why vaccines? And maybe we can just look to the words of the 15th century Dutch philosopher Desiderius Erasmus, who I understand is the first person to to take the phrase prevention is better than cure. But of course it's a little bit more complex than that. But if we do look at what the facts are in relation to antibiotics and vaccines and when they've been implemented and when we first see resistance, you'll see from this figure, which is I borrowed from a paper from a few years ago, that it only takes a few years from implementing an antibiotic to when we first see resistance. And those lines, particularly for the latter antibiotics, are really quite short. Whereas the longevity that we have with vaccines before we see resistance is much longer. And sometimes that's due to features such as serotype replacement, which we've had with the pneumococcal vaccines, which is why we keep developing more of those. We have a little bit of an arms race there. But essentially, in summary, resistance against antibiotics is common, resistance against vaccines is rare. And this is partly because vaccines are working essentially prophylactically and drugs are working therapeutically, and we'll dissect that a little bit more in a moment. But of course, vaccines are inducing immune response against multiple targets on a pathogen, whereas drugs have much fewer. And as I mentioned earlier on, one target, one mechanism. So there's really two factors here. There's the early action of the immune response that's been induced by a vaccine that gives, if you like, a prophylactic type effect by generating diversity before intervention with the immune system being harnessed. And then that second element, the immune system allows aspects of the adaptive immune system, antibodies and T-cell receptors, to have a multiplicity of targets. And not only is there a multiplicity of targets, these vary from person to person. So you have this mosaic-like effect, and this helps reduce transmission by both of these two different factors. If we look at this on a time chart, of time post-exposure to a pathogen and pathogen population size, the antibiotics, it's the vaccines and the immune response that's induced by those vaccines essentially is responsible for the red lines early on. It can check infection before you get to transmission threshold. And remember, the more cycles and the more reproduction of the pathogen that you get, the more chance there is that you're going to get variants which have resistance genes in them as well. And of course, as you go above that transmission threshold, which might be before you get clinical symptoms, you are then able to transmit the pathogen onwards. And the blue lines are essentially represent what you have when you come in with an antibiotic to cure the infection. You've already got high levels of pathogen. Your chance of transmitting and your chance of transmitting resistance to AMR become much higher. And of course, this is something I don't need to show anyone in the audience, not least my old immunology consultants who are here. But essentially, we have huge diversity of the immune system in the adaptive acquired immune response due to the potential of gene rearrangements and somatic mutations, both in antibodies and in T-cell receptors as well. So if we think it very simplistically, with antibodies, we've got potentially millions of binding sites against millions of targets. Obviously, this is limited by what our vaccine is, whether it's a very simple subunit vaccine or a rather more whole organism vaccine, but the point is made. So how do vaccines now reduce AMR? Well, there's two real main mechanisms: preventing the infections and reducing antibiotic use. So in terms of preventing infections, that's really key, and if we can reduce the burden of infection, of course we're going to reduce the rate at which AMR emerges, and we're going to reduce the amount of existing infections with AMR as well. We reduce development of resistance, and we reduce the transmission of that infection as well, and just as I showed in that time graph before. And we can get herd immunity as well, so those who are vaccinated who can't transmit have benefit for the whole population. And of course, we can reduce secondary infections as well. This is particularly important for the role that vaccines against viruses play in this story. And of course we reduce antibiotic use, and antibiotics serve as the selective component of that evolution response that allows those resistant strains to be selected, and this is both in the target pathogen that's being treated but also in bystander species as well, so other bacterial species that are present. Now the WHO have moved a long way with this. They now have an action framework they put together for the first time 5 years ago, and actually this is really quite a sensible document. It has 3 main components. 1, expanding the use of licensed vaccines to maximise impact on AMR. 2, developing new vaccines. And 3, expanding knowledge about how vaccines impact on AMR. Which bacteria to target? The WHO came out with the first priority pathogen list in 2017. It was revised last year. And this was designed to guide research. It wasn't just for vaccines, but it did serve as a useful template. And it grouped pathogens into critical target, high importance, and medium group. I won't dwell on this, but just for the context of the rest of the talk, I'd just like to draw your attention to some of the ones in the high group. There's Salmonella typhi, which causes typhoid, of course, Shigella, a big cause of dysentery, and towards the bottom, Neisseria gonorrhoeae, the causative agents of gonorrhea. And in fact, Wellcome then took this list, and in 2018, the following year after it was first produced, published a report on vaccines to develop to tackle drug-resistant infections, and this was focused around the WHO priority pathogen list as a starting point, and looked at opportunities and challenges. And essentially it grouped the pathogens into groups according to how advanced they were. Of course, there were some that are already available as licensed vaccines, some that are quite advanced, so bring to market, some to advance into early research and development, some where there really wasn't much vaccine development or prospect going on. The calls to collect on data and explore alternatives. It is quite a comprehensive report that's worth looking at. This figure on the left is quite useful. It splits the different pathogens into groups according to probability of research and development success on the x-axis and the health impact on the y-axis. You can see the licensed vaccines on the right, pneumococcal vaccines, typhoid vaccines, Hib. Then in light blue, those to bring to market, Shigella, that I've worked on in the last 7.5 years at the Gates Foundation, non-typhoid and Salmonella, which will be a big focus of my work in Africa. And then we've got the E. coli there, both enteric E. coli or ETEC, and in the green, pathogens where we needed more early R&D. So gonorrhea, I'm going to talk about gonococcus shortly, E. coli, urinary E. coli, and Staph aureus amongst others. And then some problematic bacterial infections where there hasn't been a lot of success with vaccines in that grey category. But if we now first focus on that first WHO objective, expanding use of licensed vaccines to maximise impact, some of the best real-world data that we have to date is from the pneumococcal conjugate vaccines. These data are actually quite dated now from South Africa and come from a few years back. They're just up to 2012. But what this nicely shows from national lab surveillance data in South Africa was what happened to those drug-resistant infections after the introduction of pneumococcal conjugate vaccine. And it's 7-valent, and then that was replaced by 13-valent. And all forms of drug-resistant pneumococcus went down in terms of invasive pneumococcal disease that was detected in the lab surveillance system. So really good data, and that's been replicated in multiple other studies. If we now look at a modelling study that was published in Nature in 2020, the data here are quite interesting. So now this focuses on low and middle income countries, and it basically tried to model, well, what would be the situation if we didn't have any vaccine against either pneumococcal infection or another one that I'll come into a moment. What is the impact that we have with available vaccines now? And what could be the impact if we had universal coverage of available vaccines? And this is for pneumococcus, and this is specifically in relation to antibiotic-treated episodes of infection. And it was estimated in this study that there were 57 million antibiotic-treated acute respiratory tract infections, and that was reduced by 24 million due to pneumococcal conjugate vaccine, but could be reduced by another 22 million, so almost the same amount again by universal vaccine coverage. Interesting study also looked at another vaccine, this time for a viral entity, rotavirus, commonest cause of global diarrheal deaths, even though we now have rotavirus vaccines implemented globally, not as extensively as pneumococcal vaccines yet. And going through the same exercise, even though rotavirus shouldn't really be treated by antibiotics, but we have no good diagnostics to tell what is a virally induced diarrhea compared to one with a bacterial etiology. There's an estimated 48 million cases annually that were reduced by the level of vaccine used in 2018 by 14 million episodes, but potential for another 18 million to be removed. This is in terms of antibiotic episodes going forward. And then looking at high-income country data, this was a nice study from now 25 years ago, 2000, and this was with flu vaccine and the use of that in the province of Ontario in Canada. So what happened in 2000 was that flu vaccine was offered free to the entire population, and a before and after study was done. So what the investigators did was look at what happened in Ontario compared to all the other provinces in Canada where there wasn't free flu vaccine. Uptake went up, vaccination rate went up in Ontario, and correspondingly the rates of antibiotic prescriptions for respiratory tract infections went down. So again, real world evidence for impact here in relation to the use of antibiotics, which is a major driver of AMR. So if we turn our attention now to new bacterial vaccines, the figure on the right is from a review Andy Pollard published a few years back. But essentially we've had huge success to date with glycoconjugate vaccines, so polysaccharides that have been conjugated to protein to allow a T-dependent immune response, and using that technology against the encapsulated bacteria. So here, meningococcus, pneumococcus, and more recently typhoid. We now have more of a challenge with the unencapsulated vaccine, because in a way, we've picked off the low-hanging fruit, and that's been hugely successful, as I've already shown for pneumococcus. But some of these bacteria, particularly gram-negatives, do have a sugar on the outer surface. So gram-negatives, of course, have an outer membrane which contains lipopolysaccharide, and lipopolysaccharide has O antigen protruding out into the extracellular space, and that polysaccharide can be the target of conjugate vaccines as well. These data are now, I'm sorry to say, 28 years old, which are from an efficacy study with a Shigella sonnei prototype vaccine from the NIH, and a remarkable efficacy of 74% after just one injection. Unfortunately, development of this and similar vaccines lagged behind for about 20 years because of a predominance of going after live attenuated vaccines. And it wasn't until 2010 that the vaccine was tested in children, and there was a lack of efficacy in young children where the disease is most of a problem globally. This was very much work I did during my time at the Gates Foundation for the last 7.5 years, was then trying to advance a portfolio of candidate vaccines through the different stages of clinical trial. And we now have several multivalent vaccines, so 4-valent vaccines in phase 2. There's even the Chinese vaccine in phase 3. And we hope that in the next few years we could have a licensed Shigella vaccine, which is now the commonest cause of diarrheal deaths, which doesn't have a vaccine. But other targets are tricky as well. So gonorrhea had been really a graveyard of vaccine development. There hadn't been any clinical trial for about 30 years. And then some investigators looked at the effect of what vaccines against the meningococcal group B strain in New Zealand, and there was a specific vaccine made to deal with an outbreak in New Zealand. The investigators looked for what was the effect on gonorrhea, and of course Neisseria gonorrhoeae and Neisseria meningitis share the same genus, and it was actually quite remarkable that in a retrospective case control study there was estimated effectiveness of 31%. Now, people thought that might just be a fluke, but this has been replicated in other retrospective studies, and now is being studied prospectively as well. And in fact, the vaccine that's used for this is out-of-membrane vesicles, which are tiny blebs that come off the surface of, or either extracted from gram-negative bacteria such as Neisseria, or are bled off the surface. And this was a technology I was using when I was working on my first stint of time in industry at Novartis. And our hypothesis was actually before this data came out, and I just come back from Novartis to the General Institute, was why don't we make an OMV outer membrane vesicle-based vaccine with gonorrhea with gonococcus as our starting strain rather than meningococcus, and won't that have greater efficacy than what we've got here? So we actually have a vaccine now that's being produced at the clinical biomanufacturing facility in Headington, the same facility that produced the first batches of the Oxford AstraZeneca vaccine, and we're trying to finalise a deal on funding for phase 1 studies. But we do have some really tough targets, and just talking beforehand with I think it was Charles Bangham or Chris Winnells, there's a question around Staph aureus, and there are some really tough targets that we do desperately need vaccines for, and these are called, maybe quite appropriately for the context of AMR, the escape pathogens, or if you put E. coli on the end, which it should be the escapee pathogens. And these group, and then the escapee is an acronym for the first letters, including Staph aureus, E. coli, are really responsible for a huge number of deaths that are ongoing. But these are hard nuts to crack, they're hard targets, and in fact, Pfizer failed in their phase 3 study a few years ago with Staph aureus, and just a couple of weeks ago we heard that the Johnson & Johnson Sanofi E. coli vaccine for XPEG had also failed its phase 3 study. So there are not straightforward targets. They don't have nice polysaccharide capsules for conjugate vaccines. But maybe looking just a little bit more of a brighter light looking forward, and this is something that all policymakers are moving towards now that we have, we're needing multiple vaccines, and really immunisation schedules are getting quite tight, quite crowded, is to use combination vaccines and put together vaccines against a number of different targets. And this is something we need to look at as immunisation schedules become more crowded, and as we want to move on and fit more vaccines into our schedule. And we could have vaccines against syndromes such as pneumonia, such as diarrhea, such as different forms of neonatal sepsis. And if you can then visibly bring down actual syndromic illness through vaccines, that producing evidence could be that much better, and of course we'd have greater impact on AMR as well. So for the last part of this talk, I just want to talk a little bit about communication, articulating the message. Now, as a medic, as we all are, as scientists, it would seem pretty obvious that vaccines are important for dealing with AMR, for reducing AMR, and there are plenty of publications that we can find in the scientific and the medical literature around this. So it seems pretty clear that vaccines are a really important tool. However, you can find plenty of reports, both in the mainstream media, here's an example from the Washington Post, and also even in scientific literature. This is from Science magazine. You all call it Science, but it's that talks about AMR and dealing with AMR, but doesn't even mention vaccines. So there is a gap, and this can even be a gap. I'm sorry sometimes to say, within the AMR community, and I've mentioned this to a few people as well, that really that message isn't always coming out. And why is there an issue with that? So I'm just trying to make myself a little bit smaller here. I hope I can do that. But, you know, these stories about vaccines and their impact, and there is evidence, but do we have enough evidence? And more importantly, are we articulating that story to the world at large and to the antimicrobial resistance community? And I'd like to give the example of typhoid. So this is the most recent of the conjugate vaccines. So typhoid being encapsulated as really about the only encapsulated form of salmonella. And this had become increasingly drug resistant with time, particularly in Southeast Asia. 2017, what we call extensively drug-resistant typhoid started to emerge in Pakistan, and this became more prevalent through 2017 to 2018, and a really serious public health concern. Unfortunately, this coincided with the timing of not just the licensure, which had been back in 2014 of the first typhoid conjugate vaccine, but the WHO pre-qualification of that vaccine. And Pakistan became the first country to introduce typhoid conjugate vaccine. And that was a real game changer. The predictions on this are really run into the millions in the numbers of cases that are going to be anticipated to be averted, both in terms of all forms of typhoid, but also XDR typhoid, because our immune systems don't care whether a bacterium is AMR, MDR, or XDR. It's all the same to the immune system. And these are the real-world data that came from Hyderabad, published in 2021, and these were culture-confirmed cases of typhoid, giving an indication of vaccine effectiveness there. And the figures were really super impressive. So effectiveness of over 90%, both amongst all culture-confirmed typhoid cases, that's at the top, and also amongst those with XDR typhoid. So again, probably not a surprise to anyone in this room, as I've mentioned, the immune system doesn't discriminate between different forms of bacteria and whether they are or aren't sensitive to antibiotics. It can have equal impact. But I think the question is, why did it take so long for typhoid vaccines to be introduced anywhere? Because they were available from 2014, and there was an issue around what was the disease burden, what was the right target population, policy and financing, and really we needed the WHO pre-qualification for Gavi, who worked linked with UNICEF to open up a funding window, which they did in 2017, and also economic and commercial interest. So a lot of these vaccines are particularly a problem where you're not going to make a lot of profit, and the return on investment wasn't clear. And fortunately, there are now a number of typhoid conjugate vaccines that have been produced and licensed. The one I developed in industry is produced by Biologically, and that's been introduced in several countries with funding from Gavi. And also there's one of the things that the Gates Foundation did while I was working there as well was to set up a typhoid vaccine accelerator consortium to just help fill some of the knowledge gaps and help with the introductions in these countries. And it's not straightforward for a country to do a new vaccine introduction. There's a lot of work that's involved with that. So now just returning to WHO at the end of this talk. So to what extent can vaccines reduce AMR? This was the last of the WHO points in their action plan. And they came out with a report very recently that's just been published and has estimated that the total averted burden of AMR deaths could be 500,000 from vaccine developments, and similarly they produced estimates for antibiotic use and economic burden. And also you might be aware that last year a Lancet series came out on AMR resistance, again focusing on low and middle income countries, and the estimate there was what interventions could make a difference, and amongst those interventions vaccines came high on the list. If we fed out those high priority pediatric vaccines, those that were already available, we could reduce deaths in those countries by 200,000 amongst children, and that's just with vaccines that are currently licensed. Obviously there's opportunity to reduce those deaths further with new vaccines. And there were some proposals from this report, proposals for a 10% reduction in AMR mortality, 20% in inappropriate use of antibiotics in humans, and 30% in animals. And that will go forward to the slide I'm just going to mention at the end. I just want to have a slight interlude for a moment. One of the things that I did do 7 years ago now was set up a global vaccine network focusing on bacterial vaccines, and part of the driver for this was AMR and combating AMR. This has now got over 2,000 members. I'm stepping back, so if you know anyone interested there, we're actually advertising for a new director at the moment. But it's really gathered momentum and is internationally recognised and has membership across 93 countries globally. And then I did have the chance with Sally Davis last year to hold a 2-day Science Plus meeting at the Royal Society, focusing on vaccines and AMR, and really trying to drive that policy element going forward as to how vaccines can really help in that AMR crisis, both in the human health spectrum but also in the veterinary field. We brought together experts from both those fields, and we brought together a set of messages going forward with that around the importance in that statement. And a series is going to be published shortly. I want to just mention the Gavi, the Vaccine Alliance. This is really key for the introduction of much needed vaccines in low-income income countries. And one of the interesting things, they do every 4 years a vaccine investment strategy. The last one's just gone past. But one of the things that they consider now when they're selecting vaccines and diseases to go after is what would be the impact on antimicrobial resistance. And then just to finish off, last year, you'll probably be aware there was a second United Nations high-level meeting on AMR in New York. There was a new resolution. This was somewhat more robust than the first one. There have been pledges of funding towards this, but I'm sorry to say that the amount that's pledged, if you think back to what the O'Neill report stated would be required of 3 to 4 billion a year, 100 million doesn't really cut the mustard on that. But I think that focus of the funding that is pledged is to look particularly at helping countries produce national action plans. That was part of the first high-level meeting recommendations, but where countries have had action plans, particularly the mid-income countries, they haven't been able to implement those. Just turning to the UK now, the UK has actually been pretty good in putting together its own action plan. It's now on its second action plan. This figure does just demonstrate at the top bar that there is an appreciation that even in the UK, a lot of deaths do involve to some extent bacterial infection. And the action plan was put in place just at the end of the last government and carried through with the current government, does very much have a focus on prevention, including vaccines and immunisation. So in summary, vaccines can play a hugely important role in the fight against AMR by reducing both drug-resistant infections and reducing antibiotic use, which drives AMR. And I think really what the WHO recommendations on this are very important to follow are expanding the use of existing vaccines, developing new vaccines, and maybe not just collecting data to quantify impact, but also advocating for the use of vaccines. And this has to be, of course, used in combination with other interventions as well. So I'll stop there. There's a few acknowledgements, a number of people who've helped put slides together that I've just put on this acknowledgement slide. And thank you for listening.